So that's really the information that you should be gathering before you see the young person. So now we're going to talk about what happens when you have that first session, which is the assessment session and the questions and answers that occur, and coming to a diagnosis of delayed sleep-wake phase disorder. And one question that we had to really answer, and answer pretty rapidly, was, do we have the parent come in with the young person? So you have to understand that this was back in 2006, and there weren't many people doing this type of treatment. We were aware that there were two clinical research groups that were looking at trials, these sleep interventions for young people, for adolescents. One was conducted by Dick Bootson, who essentially was running a sleep intervention for teenagers that had already been through a substance use program. And after that substance use program, if they reported just at least one type of sleep problem, so it didn't have to be delayed sleep-wake phase disorder, any sort of sleep problem, then they were enrolled into this group therapy session with Dick Bootson's trials. And I had the privilege to be able to talk with Dick Bootson, and he said that they made a conscious decision just to have the teenagers because the main argument was that it would give them a sense of empowerment. And that certainly is something that a number of people have said when they choose to have just teenagers in the room with the treatments and not have the, in finger quotes, interference from parents. The other research group was led by Ronald Dahls. I always have to think about his name before I go to say it. He's from the University of California in Berkeley, and he was running some trials with teenagers again, just with the teenagers alone and not necessarily with the parents in the room. So the question for us was really, do we go with what Dick Bootson and Ronald Dahl had done and just have the teenagers, or do we have the parent come along for the ride? Now, what we ended up doing is having the parent coming in as well. And there wasn't really a huge rationale or argument or arguments for doing so, aside from the fact that when I was working in the adult insomnia clinic and sometimes was having a teenager coming in for treatment, I would just naturally have the parent coming in. The parent just came in. And so we went through and did the questions and answers the interviews and the treatment. So it's something that I'd naturally had some previous experience in. So with that, the decision was just to have the parent come in with the teenager. And now on reflection, it was the best choice I think we could have taken. And that's for a number of reasons. The first one is that when the teenager comes in, you've got someone who's been chronically sleep deprived and is feeling chronically sleepy and unmotivated, etc., etc. And especially with that first treatment session, where you're going to be talking about circadian rhythms and the body clock, and you're basically doing a bit of science, how are you going to tell that to a sleepy teenager and have them retain that information and convey that to their parent or parents? We really can't see that working that often. But the other benefit was by having the parent in, they can actually provide, at least in the assessment session, some extra information. Some of it historical about how the young person was sleeping as a baby, as a school-age child as well. And it can actually provide sometimes a bit more insight into their current sleep problem. And I guess the other issue is that you've got, instead of the teenager that you're trying to train and educate to be their own sleep therapist, you're also getting the parent to be. So you've got two of them in the room that you're training up. And so at least with that previous example, when you've got a teenager that's just been told about circadian rhythms and they've been shown a curvy line on a graph, and they're feeling quite sleepy, they might not take that information in quite well, but at least you've got an alert parent that's also taking that in. So it can be quite useful to have the parents in at the same time as the teenager. So this really relates to this page in the PDF, the Q&As, and some of the questions that you really should be asking to try to get at the core issues of a delayed sleep pattern in the young person. This also ties into the assessment interview, the semi-structured one that we provide in the appendix. And these really do go together. So as mentioned, the assessment interview is really there to help in the diagnosis of delayed sleep-wake phase disorder. And some of these other questions we've found have been quite helpful for us as well, just clinically, or we've used some of these questions also in some of our research. But usually we have an overarching assessment interview for sleep issues. We just use the same one for regardless if the person is a teenager, young adult, or if it's even an infant or a child. But what we've done here is just take the best bits for you, and had it focused just towards delayed sleep-wake phase disorder for that assessment interview. And so here's the diagnosis for delayed sleep-wake phase disorder. So there's really 5 criteria there, and this is taken from the International Classification of Sleep Disorders, the 3rd edition. This was released in 2014 by the American Academy of Sleep Medicine. And it's really important to focus probably on these first 3. So as you can see there, criterion A is that the major sleep period is significantly delayed. So it's delayed in its timing so that they're falling asleep quite late and they're also waking up quite late. You can have evidence of a recurrent problem trying to fall asleep, as well as awakening at what's called the desired clock times. Usually, in this instance, especially with teenagers, that they have difficulty waking up for school. This is a new criterion since the previous edition, which is the criterion B, that the symptoms are present for at least 3 months. I think that's a good addition. You usually find that this sort of problem has been going on for far longer than 3 months. Most of the time we're finding that it's been, if anything, probably a year to many years that the young person's been experiencing this. And then the other aspect to this, and this is the importance of having something like a sleep diary, is that when they're allowed to choose when they want to sleep, you'll find that their sleep is improved in terms of the quantity and quality, but it's just delayed. So you'll see this on weekends, for instance, where they'll fall asleep late and they'll sleep in later. You can also find this when, say, for instance, they weren't able to get up to go to school and then they just continue to sleep in. You'll also see this in school holiday periods as well. So hence why it's important to have a sleep diary to be able to have evidence of this. And that's really mentioned there in criterion D. And then with criterion E, the whole idea, like you would see in a number of different diagnoses, is that this is really the best explanation for their current sleep problem. It can't be better explained by another sleep disorder, medical or neurological disorder, mental disorder, medication use, or substance use disorder. In our experience, the only types of sleep disorders that might come close to this, as we've alluded to already, could be an insomnia disorder. So hence why you need to see if they are able to sleep in on weekends, if they are able to. Another one is an extreme version of delayed sleep-wake phase disorder. It's rare, but we're starting to see it a bit more. And that is a non-24-hour circadian rhythm disorder. And I'll speak about that in a moment. But usually we don't find that there's many other sleep disorders or medical or mental health disorders that really do better explain the sort of problems that you see when a teenager comes in complaining that they can't fall asleep and they have trouble waking up in the morning.